All right, Dr.
So,
Mohammed, we can go ahead and start now.
okay, thank you. Assalamu alaikum and good evening, dear colleagues, dear speakers. Welcome this evening in our ETS Emirates Thoracic Society webinar session. Today is going to be Pulmonary Hypertension Group presenting a very wealthy updates about pulmonary arterial hypertension. Three of them actually coming from one institute, which is, or one place, which is Cleveland Clinic Abu Dhabi. And we hope this sort of nice combination of cardiologists and pulmonologists will really add value in enhancing the pulmonary hypertension treatment protocols in the Emirate of Abu Dhabi. We have Dr. Hani Sabur, staff physician cardiology and heart and vascular institute in Cleveland Clinic. We have Dr. Khalid Saleh, a staff physician pulmonary from Respiratory Institute in Cleveland, and we have Dr. Govinda Sashrambudi, also a pulmonologist from Respiratory Institute, Cleveland Clinic, Abu Dhabi. We will be starting with Dr. Hani Sabur. His talk is going to be for 30 minutes. He's going to talk about early diagnosis of pulmonary arterial hypertension. It's going to be very interesting, and hope to hear more updates and more information during his session. Please proceed, Dr. Hani. Thank you.
Thank you very much, Dr. Hamad. It's always a pleasure to work with you on these important educational topics. Everybody knows you've built the pulmonary hypertension in the country, and you really laid the ground for everything that's been done here. And it's the support of the society that helps us to continue as it is. So I'm going to do a sort of a case-based approach to help simplify this kind of a complex topic. And the title is, Could It Be Pulmonary Hypertension? Pearls and Pitfalls in Management of Pulmonary Arterial Hypertension. So, these are my disclosures. So it's clear that the pulmonary circulation is a little bit different than the systemic circulation in that the right ventricle is not designed or primed for high pulmonary artery pressures. In fact, the operating right ventricular function is about 25 millimeters of mercury, and it's a very thin-walled chamber. So we'll start with this case. This is a 43-year-old woman with scleroderma, a 12-month history of increasing shortness of breath, exercise tolerance restricted to walking from room to room inside her home, and 2 months history of abdominal bloating and swollen ankles and no syncope. So I'm going to just stop here for a second to point out these two high-risk features. First of all, this is a female with scleroderma who has shortness of breath to the point that she cannot even do activities of daily living in her house. And that should be a red flag for everybody, because there's no possible reason that this should be ignored. So the 1997, she had early onset of hypertension. In 2014, was diagnosed with scleroderma anticentromere positive. So as the, the key point here is she has diagnosed with scleroderma anticentromere antibody positive, and this should be itself a red flag, because scleroderma is a very high risk group. Up to 27% of these patients have PH and need annual screening by rheumatology, by echo, and other features. So in 2015, she was diagnosed with diffuse parenchymal lung disease associated with scleroderma, treated with mycophenolate and some symptomatic improvement. Her current medications are amlodipine 5, atorvastatin 10, diuretic, PPI, mycophenolate, and nebivolol. So this is very important to analyze this case, because there are many signs and symptoms of pulmonary hypertension that are non-specific, and they can overlap with many other diseases, such as shortness of breath, fatigue, weakness, angina, and syncope. But the important thing as clinicians is, why would any of these symptoms happen together in a young patient that has very low likelihood of coronary artery disease, and we don't know what her lung disease status is, but it seems very excessive in terms of her activities of daily living and limitations. Other symptoms that we see in these patients is dry cough, exercise-induced nausea and vomiting due to increased hepatic congestion and high right atrial pressures. Later stages include abdominal distension and ankle edema with worsening artery dysfunction, and then symptoms at rest in more advanced disease. Now, this is actually a common pattern even in the large multi-center registries, that patients are diagnosed 2 or 3 years after the onset of symptoms. And the mean duration between symptom onset and the diagnostic cardiac cath is 2.8 years in the REVEAL registry, which is in fact one of the largest registries from the United States. Further examination, she has facial telangiectasia, skin changes of scleroderma in the elbows and knees. She's not hypotensive. However, for a young woman with dyspnea, there are two physical findings that should attract our attention immediately, and that is the jugular venous pressure is 4 centimeters, it's raised. She has a pansystolic murmur. She's not hypoxic, even though we saw she's very short of breath. She has fine inspiratory basal crackles on physical examination and no abdominal organomegaly. So the presence of this pansystolic tricuspid murmur and elevated JVP, again, should point to the fact that we're looking at right ventricular dysfunction. Now, it's crucially important for us as clinicians to diagnose the patients early to allow the therapy to be initiated quickly. And as far back as 2012 in the original REVEAL registry, it was seen that the median survival for PH has actually improved from 2.8 to 7 years with modern therapy. And this is about 8 years later, I'm sure it's even better. However, because the early symptoms are non-specific and these patients go to many different subspecialties, the putting it all together and making the early diagnosis is crucial to avoid clinical worsening in the interim. So we need to consider PH as a differential diagnosis in patients with exertional dyspnea, syncope, angina, and progressive limitation of exercise capacity, especially if these patients have no signs and no risk factors for cardiovascular disease or chronic respiratory conditions. Always consider pulmonary hypertension in these patients who are high risk. These are high risk subgroups. So patients with a family history of pulmonary hypertension. The patient tells you that I had a daughter who has, or I had my mother or an uncle or an aunt who has pulmonary hypertension. Connective tissue disease, very high risk group. Screening is required. Congenital heart disease, HIV infection, portal hypertension, or history of specific drugs such as amphetamines or toxin intake. So then the next step is the echocardiogram. So unfortunately, the echocardiogram is where most errors occurs. As you know, a lot of the echoes focus on the left ventricle only, report only on the LV and not the RV, and this is actually a fatal error. So in this case, the patient had a properly done echo. Most of the echoes you see, unfortunately, will only have the lower two sentences. Normal systolic function, EF 65%, left atrial diameter is normal, thank you very much, nothing is reported on the RV. This is very dangerous in a patient with dyspnea. Dilated right ventricle with mildly impaired systolic function. TAPSE, which as you know is a measure of the annular excursion of the right ventricular tricuspid annulus, is reduced at 1.7. TR velocity is quite high at 4.4 meters per second. Even though there's only mild tricuspid regurgitation, the pressure can be very high. So remember, there's a disconnect from the severity of the TR and the severity of the PA pressure estimation. So it's a good thing that this patient had all of these points listed. Many echoes, unfortunately, only describe the left ventricle and have a very cursory examination of the RV. So this is what the images will look like. And for those of you that don't look at echoes frequently, this is the LV, and you notice that the septum is flattened and the RV is massive and rounded, and the RV isn't even encompassed in the whole picture, and it's compressing the left ventricle. On the 4-chamber view, again, this is the RV, this is the LV, right atrium, left atrium, and the left atrium is small and compressed by the massive RA. And you see here again, the right ventricular septum is straightened. And this is a very abnormal picture. Normally the right ventricle is 1/3 the dimension of the LV. Here it's almost 1.5 times larger. And when you see this, you always have to look for or exclude pulmonary hypertension. So a dilated RV, RA, and a D-shaped septum equals pulmonary arterial hypertension or a right to left shunt, even if the RV pressure is not detected or reported. So if you get a report that tells you there's mild TR, but the RV is dilated, always think of pulmonary hypertension. The tricuspid regurgitation is not the key to the diagnosis, that you will see from the ESC guidelines. So specifically, I want you to know something very important, that the tricuspid regurgitation in screening for PAH can result in a significant number of false negatives, and this can be fatal. So this is from a large study that looked at patients with scleroderma. So on this side, in green, you have scleroderma patients who did not have PH, as confirmed by a right heart cath. A small percentage of those, 16%, had a TR velocity by echo of over 2.8, which is above the cutoff point. That means that 16% of these patients would have a false positive echo and would need a right heart cath. Fair enough, it's a screening test, and having a right heart cath to exclude a serious disease in a high-risk group is also reasonable. But here's the more dangerous part. These are patients with scleroderma whose echo showed a TR velocity less than 2.8, in other words, not above 35, estimated by echo, later confirmed by right heart cath to be much higher. A false negative will then lead the patient not to have a right heart cath, not to be given PH therapies, and ultimately will lead to progression and death. So please remember that the TR velocity is in fact one of the less important markers of pulmonary arterial hypertension on an echo. And there's a potential for 39% of these patients who actually had proven pulmonary hypertension in scleroderma with right heart cath to have a falsely negative echo for technical or other reasons. Don't depend on the pressure alone. There are other features. So for you as pulmonologists, I'm sure you're also very aware of this. If you have scleroderma-associated pulmonary hypertension, the survival is very poor if the patients have late disease or if they have lung disease as well. So as the DLCO drops, and these are patients with ILD or more or less percentage of ILD, actually the pulmonary artery pressure is not as important as you think. It is in fact the DLCO, which is the greatest determinant of poor outcome in addition to pulmonary arterial hypertension. So these are the patients in the fourth cluster who have a poor DLCO and a mean pulmonary artery pressure that's not as high. However, they have a miserable survival of less than 40% at 36 months from onset of diagnosis. So this is a very serious point that I think we should also recognize that DLCO, which you as pulmonologists do all the time, should always trigger a research for pulmonary arterial hypertension, especially in high-risk groups such as scleroderma. So how do we interpret the echo? And how do you as a pulmonologist respond to your cardiology colleague when you have a high index of suspicion and the echo is not helping you? So first of all, do not be fooled if the ejection fraction is labeled as normal. This does not exclude pulmonary hypertension causes of dyspnea. Even if the RV pressure is reported as normal, it's often unreported or erroneous. So what the ESC guideline has come up with is this table that gives you the clinical suspicion of likelihood of pulmonary hypertension. So this is an unusual way of looking at things, but you have to integrate two pieces of information. If the velocities are above 2.9, consider that pulmonary hypertension is still there. If the velocities are less than 2.8, but there are other features of a dilated RA, RV, inferior vena cava, which we'll discuss on the next slide, then pulmonary hypertension is still present until proven otherwise. If both are present, high velocity and dilatation signs, certainly the patient has pulmonary hypertension and requires further evaluation. A low risk echo is a patient who has a low velocity and no evidence of any chamber dilated on the right side. So let's explain this. And this is also directly from the guidelines. So as we mentioned, a right ventricle that is larger than the left ventricle, flattening of the interventricular septum, the D-shaped septum, or what's called a eccentricity index, a dilated IVC, so that does not collapse with respiration. Remember that IVC should not be more than 21 millimeters, and this is already dilated. Right atrial area, more than 18 centimeters squared. Dilated pulmonary artery. These are any evidence of a dilated IVC, RA, RV, or pulmonary artery on echo is equal to PH until proven otherwise, regardless of the estimated RVSP. So I think as critical analysis of the echo, these are the things you have to look for. And if the echo doesn't contain this information, please feel free to send this back to the cardiologist and tell them, look, I need a proper assessment of the RA. So I'm going to give you an example from this case, actually. So initially, the echo technician got this value. Now look at this value. This is the TR jet. and it's not a very intense jet. You can say maybe it's not very clear. The velocity here is 3.3 meters per second. It's 300. This is 3.3, which comes to an estimated pressure of 44. So what would you do seeing this patient? Oh, the patient has pulmonary hypertension. It's not likely, not clinically significant, discharge the patient. The patient needs further echo measurements to be done before the patient leaves. I'm comfortable with the measurements. Repeat the echo in 4 to 6 months, or proceed directly to cardiac cath. So what do the guidelines say? So the guidelines actually tell you the following. If the patient has risk factors or an associated condition that is likely to cause PH, even if the echo is completely normal initially, at least follow up within 4 to 6 months. On the other hand, if the echo shows any of the abnormalities that I mentioned, either a velocity increase, a pressure increase, or dilated chamber, further assessment, including right heart cath, and certainly if the echo has all of the features, definitely right heart cath. On the other hand, if a patient has no risk factors for pulmonary hypertension and not having a disease that causes PH or CTEPH, at this point, your further investigation of right heart cath would be recommended if any of the echo features are found and you have a low threshold again for right heart cath. So you'll notice that of these 8 boxes, only one of them will tell you that an alternative diagnosis should be considered. So the echo is a very important tool if used correctly and accurately. So fortunately, we have excellent echo technicians, and our technician went around and got some additional views, got a better velocity, and you see a much better envelope here. It's very clear. And here now, the velocity is 4.4 meters per second, which translates to a velocity of 77 millimeters of mercury. So by guidelines, since the chamber is dilated and the velocities are high, this is a very high likelihood of pulmonary hypertension in a patient with a very high risk of PH from scleroderma. And here, as just to remember, the normal RVSP is actually less than 35 millimeters of mercury if measured correctly. Now we go through the diagnostic algorithm, because now you have a very high clinical suspicion. From the echo probability, we're going to consider and do other tests such as ECG, pulmonary function test, DLCO, chest X-ray, high resolution CT, and the blood gas. At this point, if there is a additional testing, it's going to be a VQ scan. And now, since the patient has manifestations of pulmonary hypertension, this is the time by guidelines to refer to the PH Expert Center for a detailed right heart cath. And if the patient has an abnormal VQ scan or CTEPH is a possibility, right heart cath and pulmonary angiogram. So why do we need to refer to the expert center, and why is a right heart cath done mostly at the expert center? Because you need to do a very detailed right heart cath. The diagnosis of pulmonary hypertension and any treatment decision is based on right heart cath. And it requires the following 3 points. The presence of pre-capillary pulmonary hypertension is confirmed with a mean pulmonary artery pressure above 25, a wedge pressure, which is an estimate of left atrial or left ventricular end diastolic pressure, less than 15 millimeters of mercury, and a calculated pulmonary vascular resistance more than 3 Woods units. All 3 of those lead to pulmonary arterial hypertension. In addition, at the first time of diagnosis, vasoreactivity testing is done in the majority of patients, with the exception of patients with connective tissue disease. However, it has to be done in patients who are idiopathic pulmonary hypertension, because this identifies a very special phenotype of patients that do very well over time. After you have made the diagnosis, it's very important that the disease severity is assessed and monitored regularly on a monthly or bi-monthly or tri-monthly basis to continuously assess risk. We look at exercise capacity, chest pain, arrhythmias, hemoptysis, and syncope. We check the patients for physical examination of right heart failure, such as JVP, edema, ascites, and pleural effusion, of course, cyanosis. Now, I'm going to tell you that there's actually a difference between the WHO functional class and the NYHA functional class that we use commonly in heart failure. WHO functional class actually includes syncope. This is not part of the algorithm in NYHA. So patients who have chest pain, shortness of breath, fatigue, and near syncope are functional class 2. On the other hand, if they have frequent near syncope with marked limitation, they're functional class 3, and recurrent syncope moves them directly to functional class 4. And it's more serious in these patients because this is hypoxic syncope. and they often become cyanotic during exercise. And finally, I'm going to tell you this clinical pearl. I have no patients who are asymptomatic or functional class 1. If you ask a patient with PH, can you go up one flight of stairs without stopping? All of them, 100% will tell you, of course we cannot go up the stairs. We have a heart problem, doctor. And if you don't challenge them in the discussion, and you just ask them, are you short of breath now? Patients misinterpret that to saying, are you short of breath sitting in the chair in my clinic? So there has to be a challenge test to confirm that they are actually not asymptomatic, but at least functional class 2. So this patient had a 6-minute walk, and this is a test we do every visit in our patients. So look at this. This is a young 43-year-old. She can only do 348 meters. Normally, you or I would be able to do 600. Her saturation drops to 89% on room air. She becomes tachycardic, but fortunately not hypotensive, and she has severe dyspnea on the Borg dyspnea index, which goes up to 10. Some blood tests are essential. We have to look for hepatitis and HIV, liver function, thyroid. Look at these numbers. Her BNP is quite high at 447. Her troponin is elevated. This is not due to ischemia. This is due to RV strain. Anticentromere, as we said, is a big marker of scleroderma-associated vascular disease. And look at the lung function test. Now, I'm just a cardiologist. I don't know how I learned from my colleagues the difficult task of interpreting pulmonary function tests, but look at her FEV1 and FVC. So it's 82% of predicted, but very importantly, look at her DLCO is significantly reduced. So significantly reduced in the setting of only mildly reduced lung volumes is really significant to say that there's a primary vascular reason why with exercise, her saturation and functional capacity drops. And this is a really important clue, especially in scleroderma and connective tissue disease patients. We go ahead and do a cardiopulmonary stress test, and I understand this is not easily available in most hospitals. 2 key points here. Her saturation drops at peak exercise to 87%. But look at this number, it's horrendous. Her peak oxygen consumption is 8.3 mLs per minute per kilogram. So that means this is almost in the range of transplant, right? We transplant patients less than 11. But the key point is she's treatment naive. And we know that this is going to change with treatment. X-ray, fairly unimpressive. No important pulmonary congestion. The pulmonary arteries seem dilated, but there is actually vasculopenia in the periphery. CT pulmonary angiogram. CT pulmonary angiogram shows a dilated pulmonary artery. See, this is the aorta for reference. The pulmonary artery is more dilated than the aorta itself, but there are no intravascular thrombi. High resolution CT. Now, I am certainly not a pulmonologist, but I've learned a lot from my colleagues that this amount of basal fibrosis and honeycombing cannot account for the massive functional capacity drop that this poor patient has, or right-sided heart failure. So there's a disparity. This is the liver ultrasound. You're looking for intrahepatic shunts or liver nodules, and the IVC. Finally, the patient comes to the right heart cath, and her right atrial pressure is 5, which is almost normal. Right ventricular end diastolic pressure is 9. Her pulmonary artery pressure is 69/19. So what is different than an echo is that you're going to measure the diastolic pressure and calculate the mean pulmonary artery pressure. All of the measurements in pulmonary hypertension are based on mean pulmonary artery pressure. The echo can only estimate the systolic pulmonary arterial pressure. The wedge pulmonary capillary pressure is normal at 10. Her cardiac output is 5.4, and the cardiac index is 3.4, which is slightly reduced, but generally preserved. And the pulmonary vascular resistance is 4.5 Woods units. So I'm going to stop here for a second to explain what is the minimum you get out of a right heart cath. Unfortunately and sadly, we have seen right heart caths that only report pressures. That is very bad because all that's doing is being a very complex interventional echo. You must calculate the cardiac output. You cannot measure it by echo. You must calculate the pulmonary vascular resistance. You must have a complete saturation run to exclude shunts, right? If you don't have that, then this right heart cath cannot be used for diagnosis. And the most important pressure that you can only get by cardiac cath is the pulmonary capillary wedge pressure. Remember, if the wedge pressure is over 15, this indicates the patient has left-sided heart disease, high filling pressures, and it's actually contraindicated to give them pulmonary vasodilator therapy. Now, there's good news about this echo cath is that the right atrial pressure is not high. That means she doesn't have overt right ventricular failure. She has RV dysfunction, but not RV failure, and this is why the cardiac index is preserved. So one of the important things that I mentioned is that you have to do serial assessment of cardiovascular of risk. And this is really important to remember. In pulmonary hypertension, we look at 1 year mortality. Now, I know as pulmonologists, you see patients with lung cancer. And in those patients, we estimate 5-year mortality, is it not? And in heart failure, we look at 5-year mortality. So this is a disease where mortality is measured in increments of 1 year. A high-risk patient has a greater than 10% chance of dying within that year. And of course, as they get worse, this number can be up to 20 or 30%. Intermediate risk is 5 to 10%, and low risk is less than 5%. How do we classify mortality in these patients? This is the way we do it. This is the ESC guideline for risk assessment. And there's a lot of points here. There's actually 8 points. And we know, and people who have worked in our clinic know, that we do all of these points very frequently, and some of them we do every visit. So we look at signs of right-sided heart failure, progression of symptoms. The presence of syncope alone is a very important factor. Functional class 2 and 3 is intermediate, 4 is severe. A 6-minute walk is very important. We do it basically every visit. And if it's less than 440 meters, it's a significant risk. This is the peak VO2. And as I said, less than 11, we go for transplant. NT-proBNP, we do it every single visit. Echo, we do quite frequently or whenever the patient's changing their symptoms. And we do hemodynamics at least once at the beginning, and if there's any change in the symptoms of need for escalation of therapy or progression of disease. And these are the important hemodynamic features that we have. So this is our patient. She has clinical signs of right heart failure, as we mentioned. She has a rapid progression of symptoms in less than a year. She does not have syncope, that's good news, but she's functional class 3. Her 6-minute walk, as you remember, is less than 440, but above 165. So that puts her in the yellow zone. Her peak VO2 by cardiopulmonary stress test is less than 11. It was 8.3, if you recall. And her BNP was over 400, which is a high-risk procedure. She did not have a pericardial effusion, and her hemodynamics, fortunately, because this is an early stage case, the cardiac index was above 2.5, right atrial pressure less than 8, and her mixed venous O2 was more than 65. So how do I classify this patient? Well, actually, at this point, she's high risk, right? And our job is to classify, if there's more than 3 elements in high risk, then the patient is high risk. And our job with treatment is to push 1, 2, 3, 4, 5, 6 parameters all into the green zone with careful follow-up and meticulous medical therapy. So what is my diagnostic algorithm treatment pathway? This is pulmonary arterial hypertension in a young woman with scleroderma. Her functional classification is due to pathological classification due to connective tissue disease. She has a severe functional class with a high risk of mortality within 1 year. So what we did was we immediately started her on endothelin antagonist, macitentan 10 milligrams, and tadalafil 40 milligrams immediately at the time of her first visit. And note the standard dose for the PDE5 is 40 milligrams of tadalafil, not 25 milligrams of sildenafil. Additionally, there is no role for sildenafil monotherapy in a patient like this. And unfortunately, you know that most of the patients that come to our center come to us on low doses of sildenafil monotherapy for years and years. And this is very dangerous because that causes them to progress. We do sequential follow-up every 4 weeks until all the parameters tested reach the low-risk state. So in summary, PH is a serious disease, often presenting with non-specific symptoms that should trigger in the differential diagnosis of exertional dyspnea, syncope, angina, progressive limitation of exercise capacity, especially in patients that have no risk factors and low likelihood of pulmonary disease or cardiovascular disease. The definite diagnosis should be made in a specialist center. By that, I mean the right heart cath and the associated testing. The echo, which everybody should order in a patient suspected of PAH, can misdiagnose, and therefore careful interpretation is needed. And you as pulmonologists will see a lot of these patients and will need to interpret the echocardiogram in a critical way to avoid these missed things in patients who present to you with dyspnea. Clinicians should aim to diagnose early for optimal treatment outcomes with dual oral therapy, including mandatory ERA and PDE5 at high dose, immediately at time of diagnosis, and close sequential follow-up with all of the risk parameters that I mentioned, at least every 2 to 3 months, with a lot of additional follow-up in between. And thank you very much for your time and your attention.
Thank you, Dr. Hani, for the nice presentation. It's very thorough. And I think the important message here, basically, young women coming with the respiratory symptoms always think of pulmonary arterial hypertension. Also, an echo could be misleading if it's done by at least an alerted echo technician or staff, because you need to alert them that we are looking for evidence of pulmonary hypertension. Otherwise, it's just a waste of time to send them there. Thank you, Hani, for the interesting talk. Now we'll proceed with this next session is with Dr. Khalid Saleh, staff physician, Pulmonology, Respiratory Institute in Cleveland Clinic, Abu Dhabi. He's going to talk about connective tissue disease related pulmonary hypertension. Very interesting topic, very common actually in our area, and hope we're going to enjoy this session. Thank you, Khalid. Proceed, please.
Thank you, Dr. Mohammed, and thank you, Dr. Ashraf, for inviting me to give this presentation. May I have the slides, please?
Okay, I'll share
it. So today I'll be talking about updates on systemic sclerosis related to pulmonary arterial hypertension, a little bit different angle than Dr. Hani. This is going to be more of a panoramic view. We'll talk about the prevalence, the diagnosis, and early detection, and then treatments and challenges. So just to give you a general perspective on connective tissue disease, this is the US statistics. Sjogren occupies the first space by far, followed by rheumatoid arthritis, then systemic lupus, followed by scleroderma or systemic sclerosis. Next slide, please. However, in terms of PH prevalence, systemic sclerosis is by far the most common to have pulmonary hypertension, followed by by lupus and rheumatoid arthritis, which is less than 10%. As shown here, and as Dr. Hani alluded, the gold standard for diagnosis of PH is based on right heart catheterization. And across many cohorts combining together, systemic sclerosis patients have about 10% chance of having pulmonary arterial hypertension. You see in rheumatoid arthritis and lupus is actually less than 1%. So the rest of the study will be talking about systemic sclerosis, pulmonary arterial hypertension, because it is the most common among the connective tissue disease patients. As shown here, the echo in this cohort actually overestimated the PA pressure. Most of these patients, as far as 50%, showed PH, while the right heart catheterization showed much less prevalence, highlighting the need for right heart catheterization. Next slide, please. I would not discuss in details how to classify patient in which group, because this is a separate topic, and actually Dr. Hani alluded briefly on how to diagnose them. But the scleroderma patient may fall in one of the 4 or 5, actually one of the 4 PAH groups. And these are based on the World Symposium of PH in 2015. There is a newer definition in 2019. However, most of the studies that I'm gonna talk about, they were based on the previous definition. In any case, so most of the scleroderma PAH patients, they fall in group 1, about 60%, and followed by group 3, which is PAH-ILD, about 20%. And group 2, mostly diastolic dysfunction, is close to also to 20%. This is based on the DETECT trial, which is a large international cohort. This is also supported by another cohort in Belgium. It's called the Ferris cohort. But we don't have strong statistics about scleroderma falling in group 4 or chronic thromboembolic pulmonary hypertension. because it's pretty much considered a rare disease. Next slide, please. So I'll be focusing for, back please, for the sake of time, I'll be focusing on group 1 and group 3 related PAH. We cannot talk about group 1 PAH without mentioning the REVEAL registry, which is an NIH-sponsored cohort of 55 centers across the US. They gathered about 2,700 group 1 PAH patients, and these are all based on right heart catheterization. And as shown in this pie chart, the idiopathic PAH is less than 50%, while the associated PAH is a little bit above 50% in prevalence. Out of the APAH, connective tissue disease is the most common, about 50%, followed by congenital heart disease and portal hypertension. So across the board, the systemic sclerosis will be about 17% of the total of the 2,700 group 1 PAH patients. In terms of incidence, combining multiple cohorts across Europe, mostly Europe and North America, the annual incidence of PAH range between 0.6 to 1.5 per 100 patient years. However, with the longer that the patient carry the disease, the incidence becomes higher, and patients with diffuse cutaneous disease may have up to 18%, the limited cutaneous up to 24% chance of developing PAH. PAH also accounts for 30% of the deaths in scleroderma patients, which highlights the need of early diagnosis and treatment. The French were the first to rise to the question whether early detection based on echocardiography will help diagnose the scleroderma patient early on. And they base it on Doppler echocardiography. Dr. Hani mentioned how to, in details, how to make the diagnosis and the pitfalls of using echocardiography. So if patients have a high TR velocity, they're considered suspect of PAH, or medium velocity with dyspnea, they go to right heart catheterization. And from there, you can confirm or refute whether patient has PAH1 or essentially ruling out PAH group 2. 6 years later, they compared these two cohorts. One is based on routine practice based on patient symptoms, and the second cohort was based on the detection as per this algorithm. And they followed patients for a total of 8 years. As expected, the routine patient cohort, they were sicker, more people in the class 3 and class 4. The detection cohort, they were mostly in the class 1 and 2. And as expected too, the mean pulmonary artery pressure was higher in the routine practice compared to the detection. And as Dr. Hani mentioned, cardiac index need to be measured. Without it, we don't have much information, as well as the PVR. Here, the routine practice is definitely worse than the detection cohort. As expected, the detection cohort has much better survivability than the routine practice. So this the limitation of this study is that it was a small study. There were 16 patients in each cohort. And this sparked further interest across the globe, mostly in Europe, and there's also studies in Asia, trying to detect scleroderma early on using a refined model. And this is the famous DETECT study, published in 2014. They have 62 centers across North America, Europe, and Asia. They collected 466 patients who are mildly symptomatic. And the kicker here is that they have to have the disease for at least 3 years and a low DLCO less than 60%. So they are not completely asymptomatic. And as Hani mentioned, most of these patients have to have some kind of symptoms. It's almost unheard of that they don't complain of any symptoms walking or doing their daily chores. The important thing in this study, most of these patients had right heart cath, and they have a nice instrument in measuring the risks for developing PAH based on 6 clinical criteria is shown here in step 1. We do PFT, pro-BNP, this is the famous one that we always do, and EKG. We collect the points, and if it is more than 300, patient referred to echocardiography. Then in step 2, you have the right atrial area, TR velocity, to collect the points, and patient more than 35 go to right heart catheterization. Based on this algorithm, they had significant sensitivity and specificity compared to the ETS guideline, which is based on the echocardiographic finding as a primary screening tool. Now, this looks cumbersome, but if anyone is interested, you can go on a website and get the study risk calculator and find your patient risks. This, for the most part, remain a research tool, and outcome measures as well as cost effectiveness of using this tool is still under debate, and further investigations going on with this cohort. Now, moving on to the treatment of systemic sclerosis PAH, we'll start with the group 1, the patient who have minimal parenchymal lung disease. As we all know, the treatment for IPAH based on the 3 pathways, the endothelin receptor antagonist, phosphodiesterase inhibitor, and prostaglandin. I want to highlight again here that all the connective tissue disease PAH group 1, they will be treated the same way as IPAH. And this pie chart is based on the REVEAL cohort. As shown here, most of the patients had monotherapy, that was back then in 2010. Less percentage were double therapy, and only 10% were on triple therapy. And if you look at the survivability curve, patients with IPAH across the board, they have better outcome than connective tissue disease. Again, highlighting the need that these patients need to be aggressively try to detect PAH and aggressively treat them. The treatment, as I mentioned, the first and the most aggressive pathway is a prostacyclin analogs. As you all know, there are multiple studies starting from 2000 forward. Here I put all the double-blinded randomized controlled trial. I'm gonna highlight some of the important studies. The Ilioprast randomized controlled trial, 13% had scleroderma and showed significant 6-minute walk. We've been using Ilioprast at CCAD more commonly, particularly in group 3, which I'll mention later. Because of ease of use, you don't have to worry about the pump or a catheter. Following is the Remodulin, and if you look at the 2006 follow-up study, showed 18% had connective tissue disease. There is improvement in survivability over 1 to 4 years. This is the sub-Q Remodulin. And in our institute, we use it for patients with advanced class 3 or 4 heart failure. And the famous Selexipag, which is one of the biggest trial, 574 patients, double-blind randomized, it was added to a mostly monotherapy, either PDE5 or ERA. They had patients with connective tissue disease and showed improvement in morbidity and mortality. And this is the Griffin post hoc analysis showing that patient with scleroderma on the left and SLE on the right has improvement in events, hospitalization or death, more statistically significant in scleroderma than in lupus. Moving forward to PDE5 pathway, we start, the first one was sildenafil, then tadalafil, and riociguat, starting from 2005, all randomized, double-blinded, very good studies. The sildenafil follow-up study, the SUPER-2, which is a follow-up on patients from SUPER-1, showed improvement in estimated survival 68%, and some of these patients had scleroderma. The riociguat with soluble guanylate cyclase, I don't have time to discuss the mechanism, but they fall under kind of like the class of the phosphodiesterase inhibitors, because you cannot use both medications, otherwise the patient will have too much symptoms and hypotension. In any case, the riociguat showed significant improvement in exercise capacity. The ERA pathway, we all know it started with bosentan, then imbusartan, then macitentan. And I will allude here to macitentan, the only one in ERA that actually proven improvement in morbidity and mortality. And then came the combination therapy, which is now more considered the mainstream of treatment, because there is, as I will show, there is significant improvement in outcome compared to monotherapy. For this, I will highlight the AMBITION trial, which a combination of imbusartan tadalafil upfront therapy compared to imbusartan or tadalafil alone, and significant improvement in clinical failure events. It is a landmark study, a very nice one. In a post-hoc analysis of the AMBITION trial, they looked at the connective tissue disease, 187 patients, of which about 120 is scleroderma patient, and they clearly showed the superiority of the combination therapy in this patient population. A nice meta-analysis. So when you have many studies, and it's nice to have what we call a systemic review meta-analysis, and this is a very nice one published by Rhee in 2015, comparing IPAH to connective tissue disease. And as shown clearly here, in 6-minute walk, IPAH patient did significantly better than connective tissue disease in 6-minute walk. So the expert, they considered that part of the failure in 6-minute walk could be arthritis, other concerns with the connective tissue disease patient. Not to mention here that some of these patients may have a subtle diastolic dysfunction, which is another topic we can spend time on. They also did the odds ratio of clinical worsening, and clearly IPAH were the winner. The significant statistical significance. The systemic sclerosis, despite some trend for improvement, did cross the one line. It's not statistically significant. Again, highlights the need that this systemic sclerosis patient need to be aggressively treated and managed. The ongoing trials, we have the triple therapy, adding tadalafil, adding selexipag to macitentan and tadalafil versus placebo, is still ongoing. Rituximab is being studied for PAH purpose using the 6-minute walk for 24 weeks as a primary outcome. Actually, the preliminary data is negative. And here we have many other medications we are not familiar with. They are working against the inflammatory pathway and to study the effect on PAH and connective tissue disease and scleroderma using 6-minute walk as a primary outcome. And rosuvastatin is also in the study, and results is pending. So the treatment of scleroderma patient, particularly the PAH1, the most important aspect of it is not to miss the elephant in the room. Unfortunately, lots of time we see that we're focusing on one thing and we forget the following what else is going on with the lung, which is pulmonary fibrosis. So let's talk about scleroderma ILD without PAH. It's highly variable depending on how you look and how you report it. Up to 40% have mild to moderate ILD. We have severe ILD depending on the duration of scleroderma. And here are the trials on ILD scleroderma patient. This is mostly for the pulmonologist. You use immunosuppressant. The next two most important trials we all know came out in nintedanib, the INBUILD and the census, improved in the decline of FVC. Then pirfenidone had later data showing improvement in mortality or trend toward improvement in mortality in addition to improvement in decline of FVC. We have the ongoing scleroderma lung trial adding pirfenidone to mycophenolate, which is still recruiting. Just to bring to your attention, bosentan was studied in only scleroderma ILD patient because it was thought to have an antifibrotic property and the results was negative. Now we move to a different, so we were covering, I mentioned the group 1 and then mentioned the systemic sclerosis only with ILD with no PAH. Now we move for the group 3 PAH, which is scleroderma /PAH/ILD. And there is a lot of controversy, but some of it was solved recently. The Artemis trial, the Artemis PH and the Artemis IPH, ambrisertan, they both were terminated early because of bad side effect. The Rio Sigwat and RISE IIP also terminated because of increased mortality. We have the bosentan trial was negative, and so was the sildenafil. The STEP IPF was also negative. However, the sub-analysis of the STEP IPF of sildenafil showed that patients with RV dysfunction have an improvement or less of a decline in 6-minute walk as well as quality of life. So yes, we've been using sildenafil in group 3 scleroderma PAH-ILD very carefully because you might have side effects from sildenafil only if they have evidence on echo that there is an RV dysfunction. Ongoing trial is pirfenidone plus minus sildenafil, which is still recruiting. The next one is nintedanib plus minus sildenafil. It has been completed recently and it was a negative study. We'll wait for the post hoc analysis, see if there's any subset of patients might benefit from adding sildenafil to nintedanib. And I would like to bring this study, which is most recently accepted in the Arthritis and Rheumatology Journal. This is from the French cohort, the HYPID. They looked at 62 scleroderma PAH versus 66 patients with group 3 PAH-ILD. As expected, the hemodynamics were much worse in the group 1 compared to group 3. PVRs clearly P of 0.005. In terms of pulmonary function, as expected, the PH-ILD did a lot worse in terms of DLCO compared to the PAH. And confirming all prior studies, the scleroderma PH-ILD has significant mortality in the first, second, and third year, as shown in this graph. Both groups had improvement in 6-minute walk. I'm sorry, the WHO functional class, 33% in group 1 versus 14% in group 3. Hemodynamics improved in both groups. However, there was no change in 6-minute walk for the group 3. One study is still ongoing and has not been published yet, presented at the CHEST, the safety and efficacy of inhaled treprostinil, patient with PH, by Dr. Waxman group at Brigham's and Women's Hospital. It was a phase 3 randomized controlled trial. They included connective tissue disease patient. As you know, treprostinil is an inhaled QID, which is much better than the iloprost. And their primary outcome was improvement in 6-minute walk at 16 weeks. Patient showed improvement in NT-BMP, improvement in 6-minute walk, but no change in the quality of life. And finally, I would like last but not least, actually, I have a few more slides. This is the review from Dr. Nathan, who considered the guru in PH, particularly in addressing the group 3 PH. As shown here in the right lower quadrant, these patients need to be referred, and as Dr. Hani mentioned, even group 1 needs to be referred to Center of Excellence. Group 3 is more needed because they can be harmed by the medication. According to him, mild to moderate PH may not need treatment, which, however, in the commentary, he did mention that scleroderma are a specific group of patients that need special attention and they may benefit from vasodilator therapy. The severe PH need individualized care. And there are studies, which I don't have time to mention, that the exercise training can improve 6-minute walk and quality of life. Finally, we talked about the elephant in the room. We also have the mouse in the room, which is the rare disease, but is more common in scleroderma. It's a group 1 prime, PVOD, pulmonary veno-occlusive disease. It is suggested by the CT scan when you have lymphadenopathy, centrilobular ground glass opacity, and septal thickening. This is a study by Gupta and Cath looking at the patient undergoing lung transplantation. They looked at the pathology. Out of 24, 18 had PH, 9 had 1+ PVOD, and 6 had 2+ PVOD. So in terms of PVOD, you have arterialization of the venules. These patients are indistinguishable from the group 1 when you do the hemodynamics. The distinguishing feature is that this patient can have flash pulmonary edema after starting vasodilator therapy. The kicker here is that they don't have to develop it immediately. Based on review articles, up to 70 patients, the median of developing vasodilator therapy is 6 days. These patients need aggressive diuresis, slow titration of medication, oxygen therapy, and because of the poor outcome, they need to be enlisted for lung transplantation. So for a wrap-up, scleroderma patient can fall in the 4 groups of PAH. I did not have time to talk about the CTEPH. It's very important that we classify them in the right group, otherwise medication can actually harm the patient, and therefore they need to be referred to expert center experienced with complicated PAH patient. And these patients also need to be part of registry to monitor patient individually and in a group to improve quality control and enroll in research trials. And I'll be happy to entertain questions at the end of the session.
Thank you, Dr. Khalid, for the nice presentation and very thorough discussion. The questions will be by the end of this all sessions. We'll move now to Dr. Govinda Saisharam Bodhi, again from Cleveland Clinic. Another interesting topic to talk about, lung imaging in pulmonary hypertension patient, an update. Dr. Govinda, thank you, and please proceed.
Thank you so much, Dr. Mohammed. And thank you, Ashraf, my dear friend, Dr. Ashraf, for giving us this opportunity for all the Cleveland team of pulmonary hypertension patients and doctors. So I'll just share my screen. I hope it is here. You're able to see that?
Yes.
Yeah. Thank you. So I wanted to talk about today on the lung imaging in pulmonary hypertension patients, focusing mostly on the pulmonary imaging, not on the cardiac imaging, because we all know that we have lots of imaging techniques, and which Dr. Hani Sabur has already mentioned about the importance of the echocardiograph and all that in the diagnosis of early pulmonary hypertension. So my objectives today will be to just enumerate briefly on the imaging options in pulmonary hypertension disease, understand the significance of lung imaging, and discuss predominantly the CT imaging modalities. Most of the focus will be on the CT imaging and the various techniques, and also talk briefly upon the newer methods of lung imaging. So pulmonary hypertension, I will touch briefly on the imaging, talk about a few slides on chest radiograph, then discuss with various examples and various conditions, the CT imaging modalities, and ventilation perfusion scan, a bit about MRI scan, and also the newer imaging options. As you can see here, the pulmonary hypertension classification we all are well aware of. And I was trying to highlight here, I know that it's a very busy slide. You can see that most of the imaging can be helpful for connective tissue disorders. Also about sometimes congenital heart disease imaging can help us to look for any shunts or any anomalies, which I will show with some example. And also the lung diseases, which are very important group of the group 3. I also talk about the various other important diseases, especially the chronic thromboembolic pulmonary hypertension. How important is imaging there? I also talk about other important things. When you look at the imaging in pulmonary hypertension, there's a vast array of modalities. You can start from the basic chest radiograph, and you'll be surprised to know that 90% of the patients with diagnosed pulmonary hypertension, if you look at the chest radiographs, there's always some anomalies. So 90% of the pulmonary hypertension patients, when they're diagnosed, already have radiographs which are showing abnormalities, the basic chest X-ray. Then we talk about the echocardiogram, which I'm not going to talk today because my focus is on the pulmonary or the lung imaging. The CT scan looks at the various lung parenchyma changes, the vascular changes, and the cardiac chambers also can be assessed. CT angiogram, the time-tested modality which we have been using, and then ventilation perfusion scan, very important for some of the real causes for pulmonary hypertension. MRI scan, in its own way, has been used for pulmonary hypertension, but not predominantly for lung imaging, mostly for the cardiac chambers. Ultrasound, as an add-on to look at any liver pathologies, portal hypertension, it can help. And pulmonary angiograms and the novel imaging methods. These are the various imaging modalities we have for pulmonary hypertension. If you look at the chest X-ray, the basic X-ray, the traditional description of enlarged pulmonary arteries. We can see that here, the arrow marks show the right pulmonary artery enlarged and the left pulmonary artery. It's also said that if you look at the right descending pulmonary artery and the left descending pulmonary artery, a measurement of 16 millimeters or more for the right and 18 millimeters or more for the left descending pulmonary artery has got a more than 93 to 94% sensitivity for mentioning that there's a pulmonary hypertension going on in a basic chest X-ray. And also the other important chest radiograph feature we all are aware is a peripheral pruning of the vessels. And you can see from here, there's a peripheral pruning of the pulmonary vessels because of the pulmonary hypertension. And also, we know that the chambers get enlarged and the measurements for the right atrium and the right heart, as we look at the total transverse diameter of the chest, along with comparison with the ratio for the mid-hilar length. It should be more than 50%. The chest X-ray imaging, as I mentioned, is predominantly focused on the right ventricular hypertrophy, also the central pulmonary artery dilatation, which I already mentioned, the right descending pulmonary artery and the left descending pulmonary artery dilatation, and the pruning of the peripheral vessels. These are the 4 important features we see in a chest X-ray. I'm not going to talk about the 2D echo, which has been already alluded upon by Dr. Hani Saboo. Chest imaging, the traditional non-contrast CT can help us. We have the high-resolution CT, which is going to help us, especially Dr. Khaled has mentioned about the importance of the connective tissue disorders, which can help us a lot for this. The CT angiogram, and we'll talk about the newer options. The CT imaging of the chest is not only for diagnosis of the pulmonary hypertension, predominantly it can help us for knowing the etiology of pulmonary hypertension, the various causes, especially the vascular, the cardiac, more importantly, the parenchymal, and also sometimes the mediastinal abnormalities, which can lead to pulmonary hypertension. The CT findings, we know very well that an enlarged pulmonary artery is a very significant finding in a CT with a contrast CT. And also you can see the chamber enlargement, a significant increase in the right ventricular size, and also the bowing of the interventricular septum, all can be seen in the CT. As you can see here, the diameter is much more than the aorta here, and we can see that this is a clear indicator for the enlarged pulmonary artery. And also you can see that when the diameter of the pulmonary artery vessels, the segmental arteries, as you can see in the black arrow here in the second slide, second photograph, and you look at the white arrow pointing at the bronchial lumen, and you can see the diameter of the bronchus is much smaller. It appears to be smaller than the enlarged pulmonary artery here. So that's a very good pointer to say that there's a pulmonary artery hypertension going on in a patient having a CT scan like this. Thrombus, we all know that the thrombus can be seen in the peripheral pulmonary vessels, pulmonary embolism, and also for chronic thromboembolic pulmonary hypertension, this thrombus finding can be helpful for us. I will discuss that in the next few slides. This is a very important, interesting case which we had much earlier. Unfortunately, we lost this patient. He had presented with this large pulmonary artery aneurysm. And as you can see here, the contrast shows a clear arterial aneurysm, which is the reason for his pulmonary hypertension. And this pulmonary hypertension was diagnosed much earlier, and then later on they could find out about the aneurysm. If you look at a very good review from the chest recently in 2019, the imaging of pulmonary hypertension based on the pictorial assay, it gives a very, very extensive description of all the various disorders which can have changes in the CT scan. There's a very big slide with a lot of detailed information. I'm not going to go into that, but remember that there are quite a few specific diseases which I'll focus upon, which have a clear CT imaging findings which can make you suspect this particular disease. Interestingly, before going to the lung parenchyma, when you look at the mediastinal and hilar lymphadenopathy, which is also found in many of the patients of pulmonary hypertension, it's found to be in 45% of the patients who are having chronic thromboembolic pulmonary hypertension. The reasons they said could be reasons because of the right heart failure, there's an increased lymphatic flow, and therefore these mediastinal and hilar lymph nodes can be enlarged. It's a very interesting observation. Pulmonary veno-occlusive disease, I will talk upon it in the next few slides, also can show mediastinal and hilar lymphadenopathy. A disease which is very close and very similar to veno-occlusive disease, the pulmonary capillary hemangiomatosis, PCH. And in these two together, it is shown that in some series of study, 80% had mediastinal and hilar lymph nodes. And even for that matter, people with pulmonary hypertension, if you look at the CT findings, at least 20% of them have mediastinal and hilar adenopathy. And there could be associated sarcoidosis as well. So that can itself cause the lymphadenopathy. Idiopathic pulmonary fibrosis, one of the best diseases which can be diagnosed on high-resolution CT scan with all the traction bronchiectasis, honeycombing, and subpleural septal thickening, all these are hallmarks of IPF. And that can be seen as one of the causes if you have a patient of pulmonary hypertension who has not been earlier diagnosed to have a pulmonary fibrosis. Also, we have patient with hepatopulmonary syndrome who can have these type of findings, which are really helpful for us with the help of a CT scan. Pulmonary vascular disorders, we cannot forget the pulmonary venous occlusive disease, which is the most important disease we need to look at, which can be diagnosed with the help of a CT scan. Close to the PVOD, in fact, people say it could be all as a one single entity. We can take it as pulmonary capillary hemangiomatosis. As you can see here, there are some classical descriptions of pulmonary capillary hemangiomatosis and venous occlusive disease, where we can see that based on the CT scan findings, we can suspect that this disorders. Smooth septal lines, geographic or nodular ground glass opacifications, as you can see here, along with sometimes pleural effusions. These are some of the important hallmarks of pulmonary veno-occlusive disease. Also, there's nodular opacities, which I'm mentioning. It is mentioned that they can almost occur to 85% of the patients of PVOD have nodular opacities in the centrilobular location. Mosaic attenuation, we all are well aware of this very important CT scan finding. It can happen in multiple diseases, but please don't forget, if somebody has a mosaic attenuation, always keep in mind chronic thromboembolic pulmonary hypertension, along with, of course, the obstructive airway disease, emphysematous lung disease, where you have diffuse variation in perfusion and ventilation, because of which you have classical mosaic attenuation. Pulmonary arterial hypertension by itself, even in idiopathic pulmonary hypertension, there are some studies which show that there is some mild mosaic attenuation, but it is not as much as what you see in chronic thromboembolic pulmonary hypertension. Also, don't forget a very important entity, chronic hypersensitivity pneumonitis, which in a long term can also cause pulmonary hypertension, which by itself can cause mosaic attenuation. So if you look at the total lung imaging findings on a CT chest, pulmonary hypertension patients, centrilobular lucences. Centrilobular lucences are very common in COPD emphysematous patients who later develop pulmonary hypertension. It is found that 30 to 70% of COPD patients can be found to have pulmonary hypertension at different stages. But again, interestingly, if you look at severe pulmonary hypertension of more than 45 millimeter mercury, it's not so common in COPD. But if you look at the total COPD scenario, we have lots of patients with pulmonary hypertension. And we all know the classical cor pulmonale. Then please look at, for a patient of pulmonary hypertension, focus on any reticulations and honeycombing and traction bronchiectasis, which I showed in my previous one of the pictures, all this indicating idiopathic pulmonary fibrosis or pulmonary fibrosis in various forms. Overall, it's found that these type of findings are seen in pulmonary hypertension patients in 8 to 12% cases. Centrilobular ill-defined pulmonary nodules, as I mentioned earlier, is very common in pulmonary veno-occlusive disease, or the PVOD. Overall, we see 40% of the patients with pulmonary hypertension, if you do a CT scan chest, they have 40% of them have centrilobular opacities or nodules. And as I mentioned earlier, up to 87% in PVOD or PCH. Cysts are also common. Especially, you'll be surprised to know that Langerhans histiocytosis can cause pulmonary hypertension, and this can occur in 90% of the patients of this LCH at a later stage. So cysts are very common in this. Last but not the least, pleural effusions. Again, some studies have shown that up to about 15% of the undiagnosed pleural effusions, in one series, they have found that the cause has been attributed to pulmonary hypertension and right heart failure alone, without any other cause. As you can see here, the classical description of the central hyperlucencies because of a classical emphysematous patient. And these you can see some nodules also. Here you have the Langerhans cell histiocytosis, where you can see the large cyst here in both lungs, bilaterally distributed. And this is the traction bronchiectasis, which you see in a classical pulmonary fibrosis patients. So there is a lot of, a wealth of findings on CT scan in pulmonary parenchymal changes. And then we have the classical CTEPH, chronic thromboembolic pulmonary hypertension, with all this mosaic pattern, as you can see very clearly here. So CTEPH, I'm trying to focus on this more in the next few slides because the next few imaging modalities which are talking about all focus on CTEPH. The advancement of imaging has helped us for better diagnosis and classification of CTEPH patients. So CTEPH is a complication of pulmonary embolism, and it's a major cause of chronic pulmonary hypertension. Lung ventilation and perfusion scans is a screening test of choice. I'll be talking about it in the next few slides. A normal scan, remember that a normal ventilation perfusion scan rules out effectively CTEPH. A high quality pulmonary angiogram is generally, we use it to confirm and define the pulmonary vascular involvement to make a decision of the treatments pattern. Also, we need a right heart cath. And then we need to look for whether this patient can be a candidate for pulmonary endarterectomy, which is a guideline recommended treatment. But for technically inoperable cases, we need a medical therapy, including Riociguat. And balloon pulmonary angioplasty can be considered for centers where there is experience with this challenging but potentially effective intervention. So diagnosis is very, very important for CTEPH and to differentiate from an idiopathic pulmonary hypertension because the treatment is entirely different. So to sum up the CT findings, the conditions to look for in a lung imaging for a patient of pulmonary hypertension, don't forget emphysema, idiopathic pulmonary fibrosis, pulmonary hemorrhages, which can cause deposition of the cholesterol in the alveolar macrophages, causing centilobular nodular opacities due to cholesterol deposits. As I mentioned here, they're called as cholesterol granulomas. Don't forget pulmonary veno-occlusive disease, which is a very important disease to be diagnosed for pulmonary hypertension etiology. Also pulmonary capillary hemangiomatosis. And again, don't forget the limited scleroderma, which can show esophageal dilatation in a CT scan. This patient, we had presented this very interesting case in the recent European Respiratory Society case presentation in the Lungs on Fire session at the ERS virtual conference from Vienna, where there's a patient has been wrongly diagnosed as a pulmonary hypertension, being treated with triple therapy, and patient was airlifted from Bahrain to Cleveland Clinic last November, December in 2019. And later, imaging helped us to diagnose that this patient has a huge left vertical pulmonary vein draining into the brachiocephalic vein, suggesting anomalous pulmonary venous circulation, which is causing a significant increase in the cardiac output and causing a misnomer for a pulmonary hypertension. And we could manage all this because of the CT 3D reconstruction imaging, which can be easily done to find out the vessels. Coming to the ventilation perfusion scan, we have the ventilation imaging when a patient can see here who has got a pulmonary hypertension. It shows normal ventilation in the right lung, but there's a slightly decreased ventilation in the central area of the left lower lobe. And then you look at the perfusion, there's a heterogeneous perfusion with multiple mismatched perfusion defects bilaterally. So it could be a classical description of a CTEPH. So a ventilation perfusion scan, the role in CTEPH is very widely studied. It has a very, very high sensitivity and specificity as compared to a CT pulmonary angiogram. And also the biggest advantage is it can avoid the complications of IV contrast administration and its side effects. Also, it was found to be more cost effective. Therefore, the 2015 European Society of Cardiology and ERS guidelines show VQ scan as the fastest imaging method to diagnose CTEPH, almost giving it 96 to 97% sensitivity and 90 to 97% specificity. And don't forget the past positive results, which can occur in some rare diseases like fibrosing mediastinitis, as you can see here. There's a complete defect here, but it is actually because of the fibrosing mediastinitis, which is blocking the pulmonary artery. MRI in pulmonary arterial hypertension is predominantly for cardiac imaging, the RV ventricular wall imaging, and to look for any other shunts, but also sometimes it can be used in CTEPH because it's a non-contrast and without any radiation risk. It can be used in some specialized centers for pulmonary CTEPH diagnosis. Coming to the last few slides of my talk, we talk about the novel imaging modalities, which are all grouped into so many categories here, but I'll just try to focus upon for a few minutes on the SPECT, or the single photon emission computed tomography, and dual energy computed tomography. And SPECT scan has been found to be a novel nuclear imaging medicine imaging. The focus is on regional lung perfusion, integrates a CT with a gamma camera, so you can use CT and SPECT together to generate 3D images, which can be helpful to look at the perfusion defects. And then we have the dual energy, where we have two different types of kilovoltage energy channels, 80 and 140, which are used to help to have a better 3D reconstruction and to have a better delineation of perfusion defects or the filling defects you can see here. As you can see here, it's all used with the iodine imaging, and you can see this clear areas of pulmonary venous defects, filling defects, which are due to the perfusion defects. Here also, there's a very clear description of all these areas of white arrows which show the perfusion defect in a pulmonary hypertension patient, the CTEPH. And what is the best option? There are a lot of discussion about it. CTPA, DCT, MRI, VQ scan, SPECT, CT, and this study is a pilot study. I think it's 2019, 18 started study, which is going to look at the evidence of the summary of the diagnostic test accuracies for various CTEPH patients. So to conclude, imaging does play a vital role in the evaluation of pulmonary hypertension patients. It's very essential for diagnosis, etiology, quantification, risk stratification, and assessment for therapeutic response. Chest CT scans should be evaluated in all patients suspected of having pulmonary hypertension. And there are newer imaging modalities like SPECT and DECT, which hold a lot of promise for the future. Thank you very much for giving me this opportunity. Thank you so much.
Thank you, Dr. Govinda, for the nice presentation. It's one of the topics that everybody always have an issue to differentiate, to look for alternative diagnoses, but you laid it down in a very nice way. Now we'll have a session now for question and answer. There was some shared question, and I'm gonna just pass it on to the speakers. Dr. Hani, you still around? Hani Sabur? If not, it's going to be between you, Khalid, and Govinda. And let's go with Dr. Govinda. You mentioned one of our guests is asking, what is the balloon pulmonary angioplasty in brief?
That's for the CTEPH when it is not a indication for pulmonary endarterectomy. So then this is being tried where we I want to have a slide. Actually, I wanted to show that, but I'm not able to show it here. Just I want to go back to my slide if you don't mind.
Sure.
So as you know that we have this multiple defects due to filling defects of the chronic thromboembolism into different peripheral arteries. And when you're not able to do the endarterectomy, just like how we do the angioplasty for your coronary angioplasty, you try to use the pulmonary route to try to dilate those peripheral blood vessels where there is significant thromboembolic areas where you can try to do the dilatation.
Fair enough. Second question for Dr. Khalid is a very common question actually for pulmonologists. Is basically
the slides to the end of the program.
Okay, Hani.
Hello, Mohammed. Yes, sorry, I was off the link for a second.
That's okay. So the question was answered by Dr. Govinda. So the second question is for Dr. Khalid is how to differentiate between, somehow to relate between PE, I presume from the question is acute PE versus CTEPH, chronic thromboembolic disease.
Actually, it's a little bit outside the topic that I discussed, but in any case, any patient with suspected, let's say we have scleroderma patient that, like Hani mentioned. Actually, this question probably Hani fits more under his talk, but anyway, I'll be happy to answer it. So part of the algorithm to work up PH patient includes always ruling out PE. This is, if you want to call it, another elephant in the room that you don't want to miss. You want to address it. So if you suspect chronic thromboembolic lung disease, and usually these are subset of patients that you suspect them, usually like lupus or people with antiphospholipid antibody syndrome, family history, the chronicity of the problem, then you might go first to the VQ scan, or if somebody is pregnant. But almost always we do CT angiogram unless it's contraindicated to rule out acute PE. If you're still suspecting CTEPH, then we'll do VQ scan following the CT angiogram. I hope that answered the question.
That's fair. Hani, do you want to add anything?
So I think the acute PE patient has a different presentation, and the CTEPH registries tell us that only 4% of patients in CTEPH actually have a known prior PE or VTE. So it's usually many years later where it's been forgotten or missed. So I think, like Khalid mentioned and Govinda mentioned, the initial test of choice is the VQ scan. The VQ scan will show you perfusion defect. If you have a lot of perfusion abnormalities in a patient with high pulmonary artery pressures, you may be surprised the CT angiogram may be reported by the radiologist as negative. And this is something we have to educate our radiology friends, because they're looking only for a filling defect, a black surrounded by white contrast. What we're looking for in CTEPH, as you all know, is webs, bands, thickening of the vessel, and that's not something they normally look for. There's specific projections and ways you can look at the data. But once you couple that with the VQ scan, then you can tell I have a left upper perfusion defect. Let's look at the upper lobe vessels. Oh, there's a blockage here. So the differential diagnosis really doesn't come from the CT pulmonary angiogram. It actually comes from the VQ scan, and then subsequently we generally couple that with a selective pulmonary angiogram that's done with digital subtraction at the time of right heart cath. And this is why VQ scan is essential to the differential diagnosis.
And also the SPECT and DECT, the new imaging technologies can help us. In fact, I was just talking to my imaging friends in Cleveland. These can be done there also. We are still underutilizing them, but we can use them for specific cases.
Excellent. Hani, another question related to your presentation was from one of the attendees. What are the symptoms of end-stage pulmonary hypertension? When you say this patient is an end-stage pulmonary hypertension from symptoms perspective?
So this is very difficult to answer because, when the patients come to us, they're often functional class 3 or 4, right? Because they're not on treatment. And we've had patients, because they're particularly young, when we put them on dual or triple therapy, their lives change completely. So I don't really ever label a patient as end stage except on the basis of hemodynamics, right? When we have hemodynamics that suggest RV dysfunction and RV failure, so high right ventricular end diastolic pressure, high right atrial pressure, lower, the PA pressure now starts to drop as the cardiac output decreases, low mixed venous index. These are patients that are looking for transplant, right? And that's when I say it's end stage and we have other items to look at. So
We can hear you.
So if Hani can.
I think you just. Anyway, I think the message here from Hani and the team is basically we already receive patients late. Actually, when we see them, they are actually in bad shape in class 3 and 4, and internationally recognized statistics is they present more than 60% present in this 2 stages. So labeling somebody end stage pulmonary hypertension is really clinical after a trial of all medication lines and after triple treatment protocols, listing for transplant. That's basically when we think about end stage. But labeling it from soon, that is actually unfair because they actually come sometimes in very bad shape. They look like they are actually end stage, but there's good chance once you start their vasodilators medications, they actually improve. And when you add combination and triple therapies, actually they improve and they live. And we've seen cases, we have seen miracles. I don't have any more questions here from the audience, but let's use the next 5 minutes just to ask a few questions that comes on and off from your experience. Okay, there's actually one question. Is right heart cath with vasodilator tested needed to identify pulmonary hypertension? Hani was, or Khalid, or Govinda, anybody?
So the question is whether nitric oxide is needed to diagnose PH?
Every PH, right or not?
Right. Usually in the scleroderma patient, most of them, they don't respond. And some people, they go without it. I think it's not that difficult to do it. And actually, some of these scleroderma patients, they have diastolic dysfunction. So many of them actually, as I alluded to, 20%, they may end up with the group 2 diastolic dysfunction. That's isolated, but you can have an overlap. People can have belong to more than one group. So it can help you decide if their diastolic dysfunction is the wedge pressure goes up. You know that there are some element of diastolic dysfunction, and it can help you in the future that can manage in terms of the more diuretics and oxygen therapy.
Once you have your slides, then you can.
But I'm sure Hani has more experience, but I know his answer because I've asked him this question before.
So sorry, I just got a call from the hospital. That's why I have to jump off. So nitric oxide is very important when we first diagnose patients because there's about 5% of patients who are generally idiopathic who are true nitric oxide responders. And these people are very fortunate because they have lived normal lives. Their mortality is not the same. They can be on a cheap medication, high-dose calcium channel blocker. So we do it practically in every patient. And I know the guidelines say that in scleroderma patients, we don't need to do it because they are non-vasoreactive from the beginning. But kind of as a standard, we sort of do them on a routine basis. If we have a patient who's clearly scleroderma lung or they have extensive ILD, we're a little bit more cautious and we may defer that test. But as a rule, every patient at the initial diagnosis, if you are lucky to find them, I think that's a very good prognostic sign.
I may add one thing to Hani. Actually, as I showed, this is something I learned recently, that many patients with advanced scleroderma PH-ILD, as we show here in the transplant group, most of them had PVOD. So actually, I don't know if in the future they're going to look into this to classify patients as high risk flash pulmonary edema with vasodilator therapy. So I'm not I don't have too much experience with this, but for my patient, I would rather do it and know they don't have flash pulmonary edema and whether they have, help us decide whether they have element of PVOD. The advanced scleroderma PH/ILD, they might have element of PVOD.
Okay. A question: what is the role of lung biopsy in suspected ILD causing pulmonary arterial hypertension? Govinda, if you want to share this, your take in this question.
So, I mean, more than the pulmonary hypertension, we know that now we have some antifibrotics, which are specifically, we use them for the classical prototype of usual interstitial pneumonia. So for that patient, we need to look for if there is a clear indication for that role for those drugs. We might need a biopsy for such patients to diagnose a proper diagnosis when you're not able to diagnose with a high-resolution CT scan findings of all three classical features of reticulation, honeycombing, and traction bronchiectasis. So I don't think, maybe Khalid can add on, if there is anything different we do for diagnosing for pulmonary hypertension. We're talking about an ILD patient having pulmonary hypertension, and to know the diagnosis of ILD for using antifibrotics, we require surgical biopsy. Khalid, you want to add something?
Yeah, I think it's very important. I agree with what you said, but it's very important to classify patient in the right group. So group 1 with normal parenchyma, there is no role for biopsy. We're not going to find anything. Group 3 PH/ILD, if it's a classic UIP, we don't biopsy. If it is probable UIP, most of these people cannot tolerate biopsy. If they have PH and ILD, also we should not, I mean, it would be very risky to biopsy them. So now we rarely biopsy these patients.
Fair enough. As a question to Hani, because it's all about echo, low pressure TR with dilated RV. Hani?
Yes, boss. So I think this. So this actually means that the patient either has one of two things: either a shunt, a right to left shunt, or a left to right shunt that's undetected, and you have to look for that. Usually, it's a sinus venosus or a scimitar syndrome. So it's a volume overload without pressure overload. And then the other one, that's a possibility also, is that the patient's right ventricle has started to fail, so that the right atrial and right ventricular pressures are now equalized. It becomes like a conduit, like Fontaine. So this is a particularly dangerous situation, and it usually indicates a very advanced form of pulmonary hypertension. So this is where the RV just becomes like a very large dilated conduit, and the right atrial pressure and the right ventricular pressures are almost equalized. So it's wide open TR. So I think we have to differentiate that based on morphology and assessment, and of course, again, hemodynamics.
Thank you. I don't have more questions, but if I ask you guys, just give take-home message in 1 minute for your topic. Hani, if you just advise in terms of diagnosing pulmonary arterial hypertension, what are you going to say for our audience?
Okay, so because the patient is young, don't miss the possibility of pulmonary hypertension, especially if they come to the pulmonologist or the cardiologist. Dyspnea in a patient who doesn't have lung disease. Chest pain in a patient who doesn't have coronary artery disease. Syncope in a patient who has both these types of symptoms. Presence of JVP, lower limb edema. Don't forget that the echo has to be focused on the right ventricle. So a normal LV is not sufficient. If the RV is not described, send the patient back for another echo, talk to the cardiologist. If the RV, RA, or IVC and PA are dilated, explain it on the basis of pulmonary hypertension, and don't stop if they tell you the TR is not normal. DLCO is very important. You guys are experts in that. A very low DLCO should prompt a specific follow-up and diagnosis. Right heart cath is a safe, simple procedure. We do it a lot. It can be used to diagnose patients and save lives. Don't use monotherapy. It's not accepted in 2020. Thank you.
Excellent. Khalid? Just take-home message, connective tissue disease, pulmonary arterial hypertension.
Right. So for all patients with group 1 already diagnosed, look for connective tissue disease. If they don't have it, they may develop it in the future. For all patients with connective tissue disease, look for PAH. If they don't have it, they were likely to have it. And as Hani mentioned, we're going to start with the double therapy upfront if they have PAH. And we need to monitor the lung parenchyma, the lung disease. Also, we have treatment to prevent progressive fibrosis.
Thank you. Govinda, a message?
Yes.
Imaging pulmonary arterial hypertension.
Yeah. So, I really should thank myself to be in Cleveland, because ever since I joined there last 5 years, I've developed this interest for the pulmonary hypertension, especially the importance of CT in that. The CT scan is the important thing for us from the message I'm going to give today. There's wealth of information there to know about the other various diseases, especially CTEF, pulmonary veno occlusive disease. I have seen a couple of patients in PBOD in Cleveland. I never saw earlier in my practice. So these are all diagnosed by very good analysis by our radiologists and assessment. So CTEF, PBOD, and also sometimes the focus on mosaic pattern. Don't forget the mosaic pattern. Always think of this CT imaging for mosaic pattern, and also the early fibrosis patients when they are not having a correlation with the severity of pulmonary hypertension. So we need to look at the diagnosis of early idiopathic pulmonary fibrosis patients also, where you may miss it actually otherwise. There are lots of patients who have a pulmonary vascular dilatation in the CT scan, but we are focusing on some other part of the CT. By doing that, we are missing the pulmonary hypertension probably in the early stage. So CT has really got a lot of information which can be utilized by all the pulmonologists who are watching this seminar today, also for other physicians. That's my message.
Okay, guys, I may conclude with one message is sometimes when you read guidelines about pulmonary arterial hypertension, how to diagnose, then Dr. Hani makes it very easy to diagnose with an echo on a Cath. You think pulmonary hypertension patient and managing them is very easy, but the message is actually not. They are very complicated patient. They have a lot of mental issues in terms of depression. They read a lot about their deadly disease. They come with a low morale, and their medication is very expensive. Their diagnosis tools and algorithm are very, very lengthy. So it's not an easy disease. So be aware of the disease. Try to hunt it, because there's tons of cases that nobody's aware of. Find early suspicion tools for you in terms of symptoms, age group, radiology, testing. Once you diagnose or think of pulmonary hypertension, try to link it to the pulmonary hypertension doctors, whether it's in Cleveland or outside Cleveland, because that's the only way you're going to save this patient, nothing else. Giving sildenafil once a day will not save these patients, where they just delay their treatment and their improvement, and actually can lead to serious morbidity and mortality. At the end of this session, I'd like to thank all our speakers. Really great session, very nice presentation, very wealthy knowledge and experience. Dr. Hani, Dr. Khalid, Govenda. Wish we meet again and again for such sessions. Hopefully next time is going to be something without social distancing, something we can talk face to face and joke. Hopefully. But until that time happens, we thank you all. Dr. Ashraf, thank you for the nice organization of these sessions. MCO and other organizers and our sponsors. Our attendee, thank you for attending. It's a very nice attendance number. It's 115, which is very good in terms of pulmonologists attending at this time after duties. Thanks indeed, and wish to see you all again, and wish you to be always well and safe. Thank you indeed.
Thank you.
Thank you, Dr. Mohammed, Dr. Ashraf. Thank you.
Thank you so much.
It's really a great pleasure. Thank you.
Thank you.